Good evening. Hello, my name is Neetu Rani. As I am completing a family nurse practitioner clinical rotation at the Family Medicine Kern Medical Primary Care Clinic and in Bakersfield, California. Today I will present an endocrine case involving an adult Hispanic male with type 2 diabetes mellitus. It without the complication. I selected this case because it reinforced the importance of the comprehensive diabetes management beyond prescribing medication. It highlighted how cultural belief, health literacy, lifestyle factor, and shared decision making significantly influence diabetes outcome. This encounter reminded me that successful management of the chronic disease is require a holistic and patient-centered approach rather than focusing solely on a laboratory values. So first, I'm going over subjective information. The patient is 52-year-old Hispanic male who presented for the evaluation of elevated blood glucose level in the and the medication refills. My my he his chief complaint was that he stated my blood sugar has been running high and need my diabetes medication refill. The patient report fasting blood glucose reading between 170 to 220 mg/dl over the previous 2 months. He admitted to occasionally missing dosages of metformin because of his work schedule. He also acknowledged consuming a large portion of tortillas, rice, surgery beverages despite of previous dietary sugary beverages despite of previous dietary counseling. He denied a polyuria, polydipsia, polyphagia, blurred vision, chest pain, shortness of breath, dizziness, numbness, tingling, foot ulcers, or recent infections. His past medical history included a type 2 diabetes mellitus, diagnosed 6 years ago, hypertension, hyperlipidemia, and obesity. His medications included metformin 1000 mg twice a daily, lisinopril 20 mg daily, atorvastatin 20 mg nightly. Family history was significant for diabetes in the both parents. Social history reveals that he work as a full time in a construction and is married, speak both English and Spanish, does not smoke, drink alcohol socially, and perform minimal structure exercise. This review system was otherwise negative. Um, except the occasional fatigue, objective blood pressure 138 over 84 mmHg, heart rate 78 beats per minute, respiratory 16 beats per minute, temperature 98.4, oxygen 98% on a room air. His height is 5 feet 8 inches, weight 218 pounds, BMI 33.1 kg. Consistent with the obesity, physical examination was largely unremarkable. Cardiovascular and respiratory examinations was normal. His abdominal examination was soft and non-tender. His feet demonstrated intact skin without any ulceration, normal pedal pulses, intact monofilament sensation, and no evidence of neuropathy. Recent laboratory findings include hemoglobin A1C 8.6%, fasting blood glucose is 188, EGFR 92 ml a minute, urine microalbumin negative, lipid panel showed mildly elevated triglycerides. Assessment, the primary diagnosis was the type 2 diabetes mellitus without complications. Secondary diagnoses include essential hypertension, hyperlipidemia, obesity. Differential diagnosis consider my differential diagnosis include poorly controlled type 2 diabetes mellitus, latent autoimmune diabetes in adults, secondary hyperglycemia due to the endocrine disorders such as Cushing's syndrome. I know the diagnosis using the patient history, physical examination previously, previous diagnosis, laboratory finding, preserved renal function, absence of ketosis, stable weight, and lack of autoimmune features. I used the American Diabetes Association Standards of Care and current primary care clinical guideline to support my clinical decision. My clinical thinking focus on determining whether uncontrolled glucose result from the disease progression of a poor adherence, the patient inconsistent medication use, dietary habits, obesity, and sedentary lifestyle strongly suggest the inadequate glycemic control rather than The alternative endocrine disorder plan is to the treatment plan include continuing metformin 1000 mg twice a daily and initiating semaglutide after discussing the benefits, advantages, effect, and insurance coverage. I select GLP-1 receptor agonist because current evidence demonstrate that improved glycemic control, weight reduction, and cardiovascular protection in the patient with type 2 diabetes and obesity. In order to repeat laboratory testing, including I order repeat laboratory testing, including hemoglobin A1C in 3 months, comprehensive metabolic panel, fasting lipid profile, and urine microalbumin. Lifestyle counseling focus on reducing carbohydrate intake, portion control, increasing vegetable and lean protein, eliminating sugar sweeteners, and achieving at least 150 of moderate physical activity each week. The patient was instruct to continue home glucose monitoring, inspect it is feet daily, and schedule annual dilated eye examination. I follow up appointments was scheduled in 3 months and sooner if symptom gets worse. Evidence-based practice. The treatment plan was based on the current evidence-based guideline. The American Diabetes Association recommends individualized glycemic target, lifestyle modification, and the use of GLP-1 receptor agonist into the patient with the type 2 diabetes who has obesity and require additional glycemic control. Recent research also demonstrate that GLP-1 receptor agonists improve glycemic control while promoting a weight loss and reducing a cardiovascular risk. Alternative therapies that were considered including adding an SGLT2 inhibitor and initiating a basal insulin because the patient had a preserved kidney function, no cardiovascular disease, and preferred avoiding insulin. And a GLP receptor agonist was the most important choice. Holistic approach and caring science. The case emphasized an importance of providing a culturally sensitive care. The patient identified traditional Hispanic food as an important part of the family gathering rather than asking him in eliminating these food completely. We collaborated to modify proportion sizes, substitute healthier option, and develop realistic dietary goals and respect his culture preferences. His wife prepared most family meals, so involved her in diabetes education could improve the adherence and long-term success. Collaboration with a registered dietitian, diabetes educator, and primary care provider would further support the comprehensive diabetes management. Gene Watson Caring Science guided my approach, particularly the Krita's process of developing a helping, trusting relationship. I listened without judgment as the patient discussed his challenges and balancing work responsibility and healthy eating and the medication adherence. Establishing trust encourage honest communication and allow us to create an individual treatment plan that aligned with the personal goal and daily routine. My care reflected a holistic approach by adding not only the patient physical condition but also emotional concern, cultural belief, and family support and health literacy and readiness for behavior changes. In conclusion, this patient encounter strengthened my understanding that successful diabetes management require more than achieving a target laboratory value. Effective care depends on evidence-based treatment, culture competence, patient education, interdisciplinary collaboration, and compassionate communication. This experience reinforced the importance of combining clinical expertise with holistic nursing care to improve long term patient outcome. Thank you so much. I appreciate you listening to me. Thanks.